the first is joint. So what is the type, like the headings usually will be, the question will be framed based on the aspects, applied aspects. The basic thing what we see with the hip joint will be the dislocation of hip joint, and we usually find in road traffic accidents also we will see the hip joint will be dislocated. So like many clues and hints will be given to help you out, like this is the question of hip joint. Once you know like it is a question of hip joint, you should know like what is the type of joint it is, what are the bones forming, ligaments, bursae, relations, blood supply, nerve supply, movements and muscles. For shoulder joint, for knee joint, for ankle joint, everywhere we have studied joints under these headings only. So every time we need to know these headings for any joint. Okay. So hip joint is multi-axial ball and socket type of synovial joint. Okay. So what are the bones which are participating? We have acetabulum of the hip bone and head of the femur. Okay, so ball is actually formed by head of the femur and socket is formed by acetabulum of hip bone. Now what is this acetabulum? If you recollect hip bone, it is actually a socket where you will see there is a Y-shaped epiphyseal cartilage. It starts to ossify at the age of 12 years and completely it fuses by 16 to 17 years. So when you just look at the acetabulum, it has a notch inferiorly. You call it as acetabular notch. Okay. Then, so when you just dissect out, I will show you one slide also where we have dissected a picture where you will see the acetabulum is filled with lot of fat other than the head of the femur. Okay, pad of fat is there. We have nerves surrounding which will have proprioceptive fibers. So hip joint is of course like very much mobile as well as stable. So because it is formed by two strong bones, it has all powerful muscles surrounding it, and of course the ligaments which surround it are also quite strong. So if you remember me telling you, like in the shoulder joint we have glenoid cavity, and the margins of the glenoid cavity will have glenoidal labrum to deepen the glenoid cavity. Similarly, the depth of the acetabulum is also deepened because of the attachment of fibrocartilage, that is acetabular labrum. Okay, this is one of the factor which helps in the stability. Apart from that, the length and oblique nature of the femur. Okay, and the mobility is due to long neck which is narrow than the diameter of the head. Okay, and then so now coming to like neck of the femur, if you just look at this section, what is the angle it usually makes? See, the neck and shaft angle usually in case of adults it is 130 degrees. Okay, then now when you describe the articular surface of the hip joint, you are finding the acetabulum is semilunar. It is covered with a half moon shaped articular cartilage which is shown in blue color. The articular cartilage is also called as hyaline cartilage. Okay, so it is deepened by this fibrocartilaginous rim which is acetabular labrum. Okay, and in the fossa you have lot of fat. The fat is filled in the acetabular fossa, and this is transverse acetabular ligament which will be bridging this acetabulum. Okay, actually this ligament, though it is not labeled, it is the ligament of the head of the femur which will be connecting the fovea, I will show you, to the transverse acetabular ligament. Okay, now when you talk about the articular surfaces, now let us talk about the head of the femur. It is 2/3 of the sphere, and at the center of it we have a pit, a depression which is called as fovea. Okay, also called as fovea. It is covered with hyaline cartilage or articular cartilage. So the cartilage will be thicker on the posterior and superior aspect. Okay, then these points are enough. These points are not required. Now let us see the ligaments. So we first need to write the list of ligaments and then we need to elaborate it. Okay, so what are the various ligaments we have? We have outermost covering all around the joint, that is fibrous capsule. Then we have, like just now I told you, like surrounding the acetabulum there is a fibrocartilage, that is acetabular labrum. We know we have three components in hip bone. If you remember those three components, it becomes easy for you to remember the ligaments. We have ilium, pubis, and ischium. So the ligament is connected from the ilium to the femur bone, iliofemoral, pubis to femoral bone, pubofemoral, ischium to femoral bone, that is ischiofemoral. So iliofemoral, pubofemoral, and ischiofemoral are the ligaments. Apart from that, I told you at the fovea, that is which is present at the center of the head of the femur, we have a ligament which is the ligament of the head of the femur. Okay, lower down, I have shown you the transverse ligament of acetabulum. Now, if you are properly understanding my classes without reading anything, also you will write capsular ligament, because I tell you repeatedly, the margins of the bones which take part in the formation of joint will generally take part in the attachment of joint capsule. Now, the capsular ligament in case of hip joint, it will be attached to the margins of the acetabulum, and in lower down, in the osteology of femur, we know this is head, this is fovea where ligament of the head of the femur or ligamentum teres is attached. This is neck, greater trochanter, lesser trochanter. So connecting the greater and lesser trochanter, anteriorly we have intertrochanteric line and posteriorly we have intertrochanteric crest. So the capsule will be extending all along the greater lesser trochanter, intertrochanteric line, intertrochanteric crest. So it will be surrounding the two articulating bones all around. Okay, so this is the joint capsule. Okay, so what is the interior lining, internal lining of joint capsule? It has synovial membrane which will be filled with synovial fluid. Okay, now see here, the joint capsule proximally, where is it attached? I told you it is margins of the acetabulum. Distally, we have intertrochanteric line and intertrochanteric crest. Line is anterior, crest is posterior. How can you say this is the posterior view? Because you are finding ischial tuberosity. So this is intertrochanteric crest. So posteriorly it is attached to the margins of acetabulum, surrounding bone, neck of the femur also. Okay, and the circular fibers which are taking part in the formation of the joint capsule, you call those fibers as zona orbicularis, especially the one which are surrounding the neck. Okay, so proximally attached to the margins of acetabular fossa, base of the acetabular labrum, distally to the intertrochanteric line. Okay, in femoral neck close to the lesser trochanter. So overall, you remember it is intertrochanteric line, intertrochanteric crest inferiorly, and margins of the acetabulum superiorly. Okay. Now the capsule is very much strong superiorly. Okay. Then all these are not required. So if you just see like the capsule, if you are just cutting the capsule, the inside lining of capsule is nothing but synovial membrane. What is the function of synovial membrane? It secretes a fluid which is called as the synovial fluid, which helps in the lubrication of joint. Okay. Then, so this is acetabulum. You have horseshoe, half moon shaped structure, which is nothing but the hyaline cartilage. So we have margins is acetabular labrum. Bridging this lunate surface of the acetabulum, we have transverse acetabular ligament. This is transverse ligament where arrow is shown. Connecting the head of the femur and transverse acetabular ligament. I told you this is round ligament of the head of the femur, also called as ligamentum teres. Ligamentum teres word also comes with liver. Sometimes ligamentum teres word comes for 3 marks question. You can talk about ligament of the head of the femur, same meaning. If you talk about the ligament of the liver is also fine. Okay. Then synovial membrane lines the inner portion. So like apart from this, you will see in this fossa, a lot of fat is there in the acetabular fossa. Okay, so there will be a bursa also, that is the psoas bursa, in order to give the lubrication. Then we have this is acetabular labrum. So fibrocartilaginous rim is attached to the acetabular margin. Okay. Now I told you I will show you one photograph where we have dissected specimen. You can see this is all acetabular horseshoe cartilage. This is transverse acetabular ligament. This is ligamentum teres, right? Then you are finding in this picture also See, this acetabulum has a like rim, fibrocartilaginous rim, that is acetabular labrum. Okay. So acetabular labrum is seen, and then we have, see, this is the ligament of the head of the femur, that is ligamentum teres. Okay. So that is better. You can see this is transverse acetabular ligament. This is fovea. This is the ligament of the head of the femur or ligamentum teres. Okay. So this is the triangular extending from the fovea of the femoral head to the acetabular notch, where we have transverse acetabular ligament. Okay. So if you observe this picture, don't read anything. See, this is the acetabulum. This is horseshoe shaped articular cartilage, lot of fat, transverse acetabular ligament, head of the femur covered with articular cartilage, also called as hyaline cartilage, fovea, ligament of the head of the femur. This is the cut area for the fibrous capsule. Okay, and this is obturator foramen, which is covered with obturator membrane. Okay, then. So everything is texted here, whatever I have tried to explain you. Then let us see the ligaments. See, this is the hip bone. Hip bone has three components. It has ilium, it has pubis, and then it has ischium, isn't it? So there are certain ligaments which are connecting from the ilium to the femur. You call it as iliofemoral ligament. Okay, it is Y-shaped ligament. This is the strongest ligament of our body. This is also called as ligament of Bigelow, and this is the ligament which makes our body stand in erect position. Okay, Y shaped. Okay, the apex is attaching to the, what is this name of the spine? Anterior inferior iliac spine. So the apex is attached to the anterior inferior iliac spine, and the base is dividing into this medial and lateral bands, which are attached to the intertrochanteric line, which is seen anteriorly. In the femur bone, the bony parts, you call this as greater trochanter, this as lesser trochanter, this is intertrochanteric line. So this inverted Y-shaped ligament is extending between the anterior inferior iliac spine to the intertrochanteric line, and it has medial and lateral bands. Near to the midline, you call this as medial band, and away from this, you call it as lateral band. So I was just talking like inside the fibrous capsule, we have a synovial membrane which extend out wherever we have like lot of friction. So you are finding there is a bursa here, okay, which is called as iliopectineal bursa, which is found between the two ligaments, that is iliofemoral ligament and pubofemoral ligament. Okay, you call this as iliopectineal bursa. Then all this I told you, this is one of the strongest ligament. This is the ligament responsible for our erect posture of our body. Now, once you are done with this, now let us see the pubofemoral ligament. See, like we know hip bone has three components. So ilium is superior, and this is the pubis bone. Okay, this is superior ramus, this is body of pubis, this is inferior ramus. This is ischial tuberosity, and this is ramus of ischium. Together you call it as ischiopubic ramus, isn't it? Now see here, pubofemoral ligament is actually extending from the iliopubic eminence of the joint capsule, and it is merging with the fibers of iliofemoral ligament. Pubofemoral. Or in simple terms, you can also write like it is extending from the pubis, okay, to the femur. Okay, so superior ramus of the pubis, and it is moving towards the iliofemoral ligament. Okay, especially towards the intertrochanteric line. Comparatively, when you compare with iliofemoral ligament, it is not so strong, it is relatively weak, it prevents abduction, and there is a bursa here. Okay, so that is the iliofemoral bursa. So iliofemoral ligament we saw. Now we will see ischiofemoral ligament. So what is ischiofemoral? See, this is the posterior view of the hip bone. This is the ischial tuberosity, isn't it? And here we have the acetabulum, greater trochanter, lesser trochanter, intertrochanteric crest. Now, from the ischium, close to the acetabular margin, you are finding the ischiofemoral ligament is coming. It's labeled here. Okay, and the fibers are merging towards the medial side or the medial aspect of the greater trochanter. Okay, so that is ischiofemoral. So from the ischium, from this view you can't see ischiofemoral. So ischium, like posterior part of the joint, we will see. Okay, so this is the ischiofemoral, which is clearly visible here. Then now, what are the various bursae we see here around the hip joint? Just look at this list. See, from the abdomen to the lower limb, I told you we have iliacus and psoas major muscles. Both these muscles together, you call it as iliopsoas muscles, which get inserted into the lesser trochanter. There you have one bursa, you call it as iliopsoas bursa. Okay, at the greater trochanter, we have a bursa, that is trochanteric bursa. At the insertion of gluteus maximus at gluteal tuberosity, okay, there also we have a bursa. At the medius also we have a bursa, okay, and ischiogluteal bursa between the ischium and the gluteal region. So these are the bursae. So we know like all these bursae are actually giving the lubrication around the hip joint. That means wherever friction is more around hip joint, these bursae will give lubrication. Okay. So then this picture is present there in your all textbooks, Vishram Singh, Chaurasia. Now if you just see this picture, I want everybody of you to practice the hip joint. If question comes, you should draw this diagram. Okay. Now let us try to understand this picture. See, this area is actually the acetabulum. Okay. And here we have like lunate surface, which is half moon shaped, right? So that is the articular surface. This point is for transverse acetabular ligament, to which we know like ligament of the head of the femur is attached. See, margins of the acetabulum, we have acetabular labrum. Surrounding that, the in discontinuous green line is actually representing the fibrous capsule. Over the fibrous capsule, thickenings will be joints. Now, surrounding this hip joint, let us see what are the muscles we have. See, the big muscle, whatever you are seeing here is gluteus maximus. If you remember the structures under the cover of gluteus maximus, we have gluteus medius, isn't it? We have gluteus minimus, right? Then we also have tensor fascia lata and rectus femoris. Sartorius is anterior compartment muscle. So that means this is the medial aspect. So on the medial aspect, we will have what are the muscles on the medial aspect? We have adductor longus, adductor brevis, adductor magnus, gracilis, isn't it? So this is iliopsoas going towards the lesser trochanter. Now these are hamstring muscles. So what are the muscles you see in hamstring compartment? Adductor magnus, and we will see semimembranosus, semitendinosus, and biceps femoris. Okay, quadratus femoris is also one of the muscles what we see under the cover of gluteus maximus. Okay, so this is pectineus we see in the floor of the femoral triangle. Two muscles. IPPA is the code I told you when I was taking that lecture. Iliacus, psoas major, pectineus, and adductor longus. Okay, these were seen as floor muscles of adductor triangle, like femoral triangle. And in the femoral triangle, what are the contents we see? Van structures. What are those? Femoral vein, femoral artery, and femoral nerve. Under piriformis, I told you piriformis is the key muscle because below piriformis we have the thickest nerve of our body, that is sciatic nerve. Okay, just below piriformis, we have this obturator internus with superior gemellus, inferior gemellus. So if you draw gluteus maximus, almost all the muscles which you see as structures under the cover of gluteus maximus are there. Then you are finding the adductor group of muscles, you are finding the hamstring group of muscles, right? Then you are seeing the floor muscles of femoral triangle with its contents. So this is the thing which I gave you like a complete summary. Now in the front means this area, right? So what muscles are we finding here? We are finding pectineus, psoas major, van structures, femoral artery, vein, and nerve. Behind piriformis we saw obturator internus with superior and inferior gemellus, gluteus maximus, greater sciatic notch with its contents, that means sciatic nerve. Above we have reflected head of rectus femoris and gluteus minimus, below pectineus and obturator externus. Okay, all these are the same thing. Now coming to the blood supply. So what are the blood vessels? We see femoral artery, we did, right? So femoral artery will have certain branches like from the profunda femoris, we get medial and lateral circumflex femoral arteries, obturator artery, superior and inferior gluteal arteries. Okay. Now once you are done with the blood supply, then let us see some. There is a condition which is caused due to non-availability of blood supply to the neck and head of the femur, which may lead to an avascular necrosis. Head of the femur is supposed to be complete round like this, because these blood vessels are avulsed. Avulsed means they are broken down due to some injury, or there may be some blockage. Then this particular area will not receive any blood supply. Okay, so then this will lead to a condition which is called as traumatic arthritis. Okay, it can lead to serious hip injury or fracture. A hip fracture can cause a condition called as avascular necrosis. Okay, the surrounding cartilage, which is articular cartilage, it becomes damaged, and over time it causes pain and stiffness. Okay, now what are the nerves? If you remember me telling you, front of the thigh, nerve supply comes from femoral nerve. Medial compartment of the thigh, the nerve supply comes from obturator nerve. Posterior compartment of the thigh, the nerve supply comes from sciatic nerve. So all these nerves, they are actually supplying the hip joint apart from the nerve to quadratus femoris. So there is a referred pain to knee joint if there is any injury even to the hip joint, because the nerves which are supplying the hip are also supplying the knee. Hence, it may lead to referred pain. Okay. So now let us see what are the various movements we have. Flexion is movement which is seen like forward when you step ahead forward, that is around 120 degrees. Extension is when you take your leg behind, that is extension, which is around 20 degrees. It takes place around the axis of head of the femur. Adduction is when you bring attention position. Okay, that is adduction. Abduction is when you take a stand at ease position, isn't it? So abduction is 0 to 45 degrees and adduction is 0 to 25 degrees. Okay. Now, what are the various muscles which are producing? This table is there in your textbooks also. This table is must. So, flexion is brought about by iliopsoas, pectineus, sartorius. Extension, gluteus maximus, hamstrings. Adduction, adductors. Abduction, gluteus medius minimus. Medial rotation, gluteus medius minimus. And tensor fascia lata you can add. Lateral rotation, gluteus maximus. Okay. So these are the muscles. Yeah, in fact, this picture helps you to understand where these muscles. This is the posterior abdominal wall. This is the psoas major muscle. This is iliacus. Together you call iliopsoas, and it gets inserted into lesser trochanter. This is our femoral triangle where we have femoral vein, artery, and nerve. Floor we are finding the muscles like adductor longus, pectineus, psoas major, right? Then iliacus. So below adductor longus, we have adductor brevis and adductor magnus. This is front of the thigh where we have quadriceps femoris, right? What are those? Vasetus medialis, intermedius, lateralis, and rectus femoris. Okay. So together you call them as quadriceps femoris. This is the sesamoid bone called as patella, which is formed in the tendon of quadriceps femoris, and this is ligamentum patellae, which we saw in knee joint getting attached to tibial tuberosity. Okay. So this is posterior thing. You are finding the first muscle is gluteus maximus. These are hamstring muscles we saw in popliteal fossa and sciatic nerve also. We have certain muscles like, what are those? Towards medial side, we have semimembranosus, semitendinosus. Towards lateral side, we have biceps femoris. We also see, if you lift these muscles, adductor magnus. These are medial and lateral head of gastrocnemiae. In the popliteal fossa, we are finding popliteal artery, popliteal vein. Sciatic nerve is bifurcating into two, tibial nerve and common peroneal nerve. Okay. So if you cut gluteus maximus, underlying that you will see gluteus medius, underlying this you will see gluteus minimus. This is our key muscle, piriformis. Below piriformis we have sciatic nerve, and all these are underlying muscles, obturator, internal, superior gemellus, inferior gemellus, and quadratus femoris. Okay. So all these are muscles. So let us see the applied anatomy. I told you avascular necrosis. Suppose if blood supply is not proper to the head of the femur, then it may undergo necrosis. So that is the avascular necrosis. Head of the femur is actually suppose if there is any dislocation, so head of the femur may shift upwards also, where the gait is disturbed, and you will see Trendelenburg's test is positive. Perthes disease. So if you see there is flattening of the head of the femur, you call that condition as Perthes disease. There are different grades and different types of the fracture of the neck of the femur, which may be immediately below the head or in the middle of the neck, or connecting the greater and lesser trochanter, intertrochanteric line. This is the fracture at the shaft. This is the fracture at the greater trochanter, lesser trochanter, anywhere. Okay. So, Perthes disease is avascular necrosis of the femoral head. Now, congenital dislocation of hip. It's a condition where head of the femur is dislocated so badly it is moved out of the acetabulum and it is resting above the acetabulum. Okay, so that is congenital dislocation. That means by birth itself you will see this type of dislocations may be there. Just a minute. Congenital dislocation of hip. So this is the type of support which is given to the newborn baby to bring this dislocation back to normal. Okay, all these stress are actually not required. Okay, see, this is the typical position which the baby has to be carried. In fact, it is very good to carry the baby in this position if there is any congenital dislocation. So if there is any such dislocation, automatically head of the femur will be fixing into the acetabulum. Okay. So this is actually Trendelenburg's sign. Positive, the hip abductors are unable to control the drooping of pelvis when the opposite leg is raised. When the opposite leg is raised, actually our hip is actually in straight line. But suppose if it is tilting, that shows the gluteus medius minimus have been paralyzed. So that is actually Trendelenburg's test positive. Okay. So all these are not required, but I just don't want to trouble you with excess information. Common injuries you see here are dislocation. Femoral head moves out of acetabulum. Usually it goes posterior into the notch. So typical flexion. I'm keeping this slide for a longer time, but because a question may be framed in this way. Okay, so you will see usually the hip head of the femur may be dislocated so badly it is going into the knots. Typically, the position of the limb is flexion, adduction, and internal rotation. Okay, we'll see this dashboard type of injuries in traffic collision type of accidents. Patient will come with extreme pain. Obviously, deformities will be there, and person will not be able to move the limb at all. Okay, so this is in X-ray also we can check for the fracture of necks. This is the X-ray of hip where you find acetabulum, head of the femur. Same thing what you study in osteology you should tell. Neck of the femur, greater trochanter, lesser trochanter. Okay. So osteoarthritis, I also told you when I was doing knee joint, if the articular cartilage is getting degenerated, and in that place, if you see the formation of osteophytes, then you will see the bones are coming directly in contact. They start rubbing, because of which pain is actually felt. But osteoarthritis of hip is comparatively less common when you compare it with knee joint. Okay, all these are not required. Total hip joint replacement surgeries are generally performed if there is lot of